Good evening. My name is Miriam Cunningham. Today I'd like to share insights into the motivation, methodology, functionality, lessons learned and good practices to date from mHealth4Afrika. So based on our strategic long-term relationships with national governments across Africa, we identified that a key concern from their perspective was to leverage technology to strengthen universal healthcare delivery. And in the context of the UN Sustainable Development Goal 3, governments around the world are working towards strengthening the impact of, as well as increase access to healthcare delivery. Coherent strategies and enabling regulatory environments are required to support universal access to patient-centric healthcare delivery. And equally importantly, appropriate skills development programs, including digital literacy, are required to provide the necessary foundational capacity to facilitate complementing existing available medical expertise with appropriate health-related technologies. In the context of a significant shortfall in available medical professionals, including doctors, nurses, medical and lab technicians in resource-constrained environments, particularly in Africa, Caribbean and Pacific Group countries, appropriate technology adoption has an important contribution to make in the context of strengthening impact of and scaling access to healthcare delivery. So if technology is to be widely adopted in healthcare ecosystems, the minimum requirement is an appropriate electronic health record. And WHO defines an EHR as real-time, patient-centric records that provide immediate and secure information to authorized users. They typically contain a patient's medical history, diagnosis and treatment, medications, allergies, immunizations, as well as radiology images and laboratory results. Despite progress being made across Africa, Caribbean and Pacific Group countries in introducing electronic patient records in larger urban hospitals, paper-based registries are often the default data capture method in most primary healthcare facilities, particularly in Africa. And unfortunately, many of the health technology solutions introduced by donors over the last decades have tended to address the specific programs they're funding. So whether that's ART to support HIV/AIDS or tuberculosis, for example. And as a result, few eHealth or mHealth solutions have adopted a more holistic approach to patient-centric care or reflect the range of necessary services provided to local communities. And there's now an increased realization that using siloed eHealth or mHealth solutions is not sustainable, as this tends to negatively impact on the overall continuum of care, waste scarce resources through data fragmentation, and duplication of effort. So in this context, mHealth4Afrika secured funding from Horizon 2020, the European Commission Research and Innovation Framework Programme. And our objective was to co-design a comprehensive patient-centric healthcare platform for use in resource-constrained environments around the world. And designed to be adaptable, extensible, modular and multilingual, mHealth4Afrika integrates the use of electronic health and electronic medical record functionality with the use of medical sensors at the point of care, data visualization, data support tools. And it also supports automatic counting of aggregate program indicator data, which is required by ministries of health, as well as SMS appointment notifications and integration with a system to streamline laboratory tests for patients. So the objective of mHealth4Afrika is to strengthen healthcare delivery in resource-constrained environments by replacing on a stage basis both hard copy patient registries and any siloed or program-specific electronic records currently in use. So mHealth4Afrika worked in partnership with ministries of health, district health offices, clinic managers and nurses in healthcare facilities in Ethiopia, Kenya, Malawi and South Africa to inform the required functionality, workflow and usability requirements. And our approach to supporting sustainability is based on building local capacity through cooperation with local university partners. So mHealth4Afrika aims to improve the quality of care by strengthening the capacity of healthcare professionals to diagnose and treat patients. It makes it easy to both capture comprehensive medical histories and current medical conditions and identify potential trends or risks based on previous visits to support continuity of care and follow-up. It supports a preventative focused healthcare strategy by focusing on leveraging appropriate technology to strengthen community trust in healthcare delivery, which would encourage greater frequency of contact around all healthcare needs, supported by community healthcare workers. It helps save critical clinical time at healthcare facility level by aggregating the programme indicators which are required by the Ministry of Health each month. And it aims to strengthen clinical and diagnostic skills at health facility level by facilitating online access to critical educational materials from nursing and medical schools. So we undertook a co-design process, so collaborative open innovation and design science research techniques, and an agile development process. So necessary ethical approval is required in each country, and this is normal for interventions related to healthcare. It's not possible for someone just to go into a clinic and start doing work. This requires supervision, which is done through ethical approval, either at national level or through an institutional ethical approval board. So we worked closely with policymakers, district health offices, clinic managers and healthcare workers to co-design and validate a number of iterations of the mHealth4Afrika platform. And this iterative consultative-based approach helps accelerate both prioritizing and incrementally refining the program-related data sets, necessary functionality, workflow and usability issues. And working with the community was critical to build trust, because for a lot of the intervention sites that we worked in, the feedback they provided was that previously when interventions had been provided, it was a top-down approach, whereas we took a bottom-up approach by consulting with the people that would actually use the platform and then designing it to address their requirements, rather than taking a technology push approach, which was we already knew the answer and we were giving them a solution. And that doesn't work in healthcare, that's been proven. Qualitative data collection and ethnographic observation techniques were used during the needs requirement, the baseline study, and the platform validation approach. And taking a collaborative open innovation approach and co-design inevitably requires more time, because you're consulting with the beneficiary community in advance of preparing the intervention, and then you're working with them throughout the intervention. As a result of doing that, you have to be open to the possibility that what you started with, whilst everybody may have agreed they were the priorities at the start, based on actually seeing a technological solution in the field, the priorities of the end users may change. And this requires the intervention team to be quite flexible and work on what will have the best results for the project. So that does have a time and a cost constraint. In our case, we were addressing mandatory program-related data required for use in 4 countries, and we worked across a number of different programs. We also deliberately picked, in cooperation with the Ministries of Health and the district health offices, a mix of types of intervention sites. So historically in ICT for development, pilots are done in sites that have the best chance of success so that the solution is proven, but we took a different approach. We wanted to see how we could work with sites that are underserved in low resource settings. So we specifically requested the Ministries of Health to allocate permission to work with sites across different demographic areas and different areas with different types of infrastructure. So we worked in 4 areas in the countries. So in northern Gondar, which is Amara region in Ethiopia, which is far away from Addis, Bungoma County in western Kenya, Zomba and Blantyre in southern Malawi, and the Eastern Cape in South Africa. So we picked low resource, underprivileged areas, and we worked with the healthcare workers to design a system that would work in their environment. So when we look at the platform areas, we started from the perspective that there is an existing underlying system which is used for the aggregate data sets in a lot of African countries, which is DHIS2. So it's used to do the counting of the number of people that come for different interventions. So we wanted to see if we could build a data model on top of that system, which when we started was meant to do 2 medical programs, and over the life of the intervention it was expanded to 12 medical programs because this was what was necessary to actually serve these communities. So we developed a custom application which used Angular JavaScript and a dynamic user interface to interact with the data model through a web API. So the data model was stored in DHIS2, and by virtue of using this custom application, we could have a dynamic rendering of workflow and data points. So it meant over time, if we wanted to add a data point or we wanted to change the workflow, we didn't have to redesign the user interface. And that's very important for long-term sustainability. Then we also wanted to have a standards-based approach. So we developed a HL7 FHIR service, and this was to support data exchange in a number of cases. So we have, I'll show you later, we collected sensor data at the point of care through using medical sensors, and we wanted to be able to transfer these data sets directly into the electronic medical record. We also wanted to automatically transfer lab results from a laboratory system, and we wanted to support movement of people by providing the ability to import and export individual patient records, which would support referrals. So we developed an Android application to display the readings from the CLE-approved Bluetooth sensors, and a Windows application to display the readings from the USB sensor, which in our case was HemoQ. So now I'm going to stop sharing this, and I'm going to show you. Yeah, so now you're seeing the application, yeah? Okay, so when we developed this, so this is for a healthcare center in Ethiopia. So we had a number of technical challenges, but one of the technical challenges we had is that we were working in countries that have 2 different calendars. So we have the Gregorian calendar, which is used in most countries, and in Ethiopia, they have an Ethiopian calendar. So that was one of the issues that we had to address. So when this is data, dummy data that we did for one of the Ethiopian health centers. So when the healthcare professional logs into the system, obviously there's access rights, and the person can only see the data sets that they have permission to see. So when we set up the system first, we started from maternal health care because maternal health care is provided as a free service in all countries in Africa. Then we added on child under 5 because obviously the newborn children had to be traced through their immunizations and all the different services that they receive until they're 5. Then we were requested to add on family planning, cervical cancer screening, then gynecological outpatient. Then, as a result of the healthcare workers seeing that, then they wanted us to add the other medical services that are provided in these clinics, which includes ART for HIV patients, tuberculosis, and diabetes. So what a Pacific healthcare worker will see won't be all of these data sets. It'll be whatever's relevant to their environment. So they log into the system, they see the patient list, and then they go through selecting a patient. I'm just going to turn down the sound. Okay, so here we're clicking on the patient and then we're viewing the profile. So when we go into the profile initially, we will see the basic data about the person. And this is the same regardless of which medical service they're receiving. So here we have access to the patient information. We have access to the risk factors and the risk profile. And the risk factors are added by the medical staff as they go through. So over time, they can see you can add in specific risks, and this is available to different people. And then on the identifier for each page, we put the date of birth, the medical record number, and in this case, because this lady is doing maternal health, she has the date of delivery. So these are the different programs that this lady is enrolled in. So first of all, she starts off with medical history and registration, and then over time, she may be added to maternal health, family planning, cervical cancer screening, and then they may go to a specialist outpatient department. And then eventually they may have to come to outpatient department, or they may have problems with diabetes. So for this specific lady, these are all the programs that she's enrolled in. So when the healthcare professional goes in first, before they go into a specific program, they can see if there's any risk factors that they have to bear in mind when they're dealing with this person. So this is done through dynamic rendering of the data. So we collect up all these data sets from the programs that the person is involved in. And this is dynamically rendered based on the data from the last visit that the person had. It lets the healthcare workers see what the situation is. If there's something they need to specifically pay attention to, it's flagged in the system. So this is automatically rendered by the system. So this data set can be larger or smaller depending on how much data is collected about an individual person. Right, so now we're going to move on to the patient overview. So now we're inside a program, so we're in medical health, maternal health. We see the same initial block, the patient information, then we have the risk factors and the risk profile, and now we have the stages of the medical program that we're in. So this lets us see where this lady is at in terms of the visits she's attended, and this also gives access, this is dynamically rendered from the system. It gives them an overview of where they are in terms of progress across different data points. So now we're going to go into the first part, which is the pregnancy cycle. So here we see the different visits that the lady's had. So we can see that she's recorded all of the ANC. And then, yeah, I can't do anything with that. So when it's green, it shows that the person has attended this visit. So this gives a record of all the appointments that the person's had, and then it gives a rendering of the different readings collected through the different points. So we looked at, so this was part of what I was saying through the video. We had to provide support for both the Ethiopian calendar and the Gregorian calendar. And in terms of overall functionality at a facility level, we provided functionality to be able to search a patient list, to be able to look up clinic appointments, to set access rights for healthcare workers as system users, and then there's a dashboard that provides facility reports, summary reports on how many visits they've had, program indicators, and the ability to import and export. And then from the patient-centric perspective, we had the patient profile, which included the risk factors, and the risk profile, which is based on decision support. And then we encoded all of the programs that were required across the intervention sites that we had, which was primary healthcare facilities, and referral hospitals in the case of Kenya. So they required to be able to take the medical history and the obstetric history. Then for the maternal program, they required a pregnancy test, ANC 1 to 8, delivery and postnatal, then family planning, cervical cancer screening. For child under 5, we have a number of sub-programs, which is at birth consultation, growth and nutrition, immunization, childhood illnesses, vitamin A and deworming. And then for tuberculosis, over the life of the project, we developed quite an extensive TB program, because obviously in some countries this is still a very active complaint that has to be dealt with, and the patients go through different types of medical interventions, and that all needed to be recorded. Then ART to support voluntary screening and ART consultation for HIV patients, diabetes, and then outpatient. Had a number of areas: general, pediatric, and gynecology. So then we also introduced in the facilities that we worked with the use of Bluetooth medical sensors. So this is something that had never been used in any of these sites. So we did extensive research, and we selected a Pacific supplier that provided access to a finger pulse oximeter, blood pressure, which could be on the arm or could be on the wrist, to allow for different conditions and different levels of anxiety over getting their blood pressure taken, then a glucometer and a contactless thermometer. So here in the picture, you see one of the nurses looking at using the sensor and looking at the results on the tablet. So they take the sensor, they take the readings. I'll show you now. So this is the Android application. So the nurse puts the device on the patient and explains to them what they're going to do, because obviously if you're taking somebody's blood pressure, you don't want to make them more anxious before you take their blood pressure. So they put the device on the patient, and then the person can see on the device what the reading is. The reading is automatically recorded in the Android device, and it also uses decision support to flag to the healthcare professional if this is a normal reading or an abnormal reading. And then the sensor readings are directly passed using HL7 Fire to the electronic patient record. So in terms of lessons learned, so we worked deliberately in tough environments. So we wanted to test different hardware configurations based on the infrastructure that was available in different countries and different healthcare facilities. And we started off very optimistically, thinking that tablets would be a massive solution. And unfortunately, the reality in the environments that we worked in was that there were a lot of challenges using Wi-Fi because predominantly of the materials in the healthcare facilities. So they tended to have corrugated iron roofs, they tended to have metal across the windows. So all of these issues were problematic for Wi-Fi. And the chips in the tablets at the time weren't really strong enough to work as effectively as they should have worked. So in the end, we ended up installing a local area network in the facilities. Then in terms of digital literacy training, obviously this is a foundational aspect of introducing electronic healthcare records. So if you have staff in a facility that have never used a device other than using their phone, and using your phone is quite different to dealing with a live patient and collecting data and paying attention to the patient and collecting the data. So we spent a lot of effort on digital literacy training, and this was an aspect of this project that was linked with the site. So SSIT, the Society for Societal Implications of Technology, has a site which Paul and I co-founded. And one of the aspects that the site cooperated on this much larger initiative was to support digital literacy training, because this was something that the site volunteers could do that wasn't related to medical data and therefore didn't have ethical approval requirements, and it was something they could do as a way of helping their community. So they went into the healthcare facilities and they provided digital literacy training, and this was supported by a larger program within mHealth4Afrika. So we installed typing programs on the local server in the healthcare facility, and then we did a lot of hands-on training, and that's a significant requirement. No matter how user-friendly an application is, if the person using the application doesn't have confidence typing in the system, they will not be able to collect the data efficiently and pay enough attention to the person that's there for the intervention. Then in terms of technologies, we had to be quite creative because there were a lot of limitations with the underlying platform, which wasn't well documented and wasn't envisaged when we started this. And we learned a lot of lessons when we upgraded the applications. So that was a bit painful. Then we obviously all know the importance of an intuitive user interface, and in healthcare, if we can provide decision support, that is a massive benefit of using a holistic approach in a healthcare facility. Because if a nurse or a healthcare professional is looking at a physical record, they only see the data related to the medical intervention, the medical program that they're providing. The main advantage of having an electronic healthcare record is that you can take all the data sets, and by providing by using decision support, you can show an overall view of the person that goes beyond what somebody can see from the last visit. So you can see if somebody's going in the right direction or somebody's not going in the right direction using data visualization. So that part has to be, that's the main benefit of using electronic records. Then from a standard-based approach to interoperability, we implemented a HL-FHIR service which hadn't been used with the back-end system that we were using, and that also had a lot of lessons learned. So then in terms of good practices, from a methodological perspective, we chose to use agile development process and design science research, and that was the appropriate configuration for the constituency that we were working on, because we were focused on a cross-border orientated multi-country proof of concept. What we didn't want to do was develop one system for Ethiopia, one system for Kenya, one system for South Africa, and one system for Malawi. That made no sense from our perspective. We wanted to have one system that could be used across multiple countries. And by using agile development processes, we could interact continuously, very regularly with the healthcare workers. Like I could go in and work in a clinic for 4 or 5 days. I could sit and work with a nurse, and then an hour later I could show them something and they could say, oh yeah, that makes sense, or that doesn't make sense, or I didn't quite think it would work that way. And this sort of interaction is very important because people need to trust the system, and they need to see that when you're collecting data from them, that there's a benefit to them in you collecting that data. Then we also spent quite a lot of effort on doing the needs assessment and the baseline study. And that was important because ultimately in an ICT for development intervention, we need to be able to have scientific-based findings of where we started from, where we got to, and what were the challenges, and what changed in the environment positively and negatively. And we can't do that if we don't have a baseline study. And then obviously the value of co-design. We have active engagement with the end users. This increases buy-in, and we're able to respond quickly to requirements and validate those in real life environments. And then from the perspective of human factors, obviously once you go into an environment that hasn't used technology before, there's two components that fundamentally have to be addressed. One is the digital literacy training to address the skills gap, and the other is change management. So the way people think about collecting data and the way people behave in the real life environment changes once you put technology in its way. And it's very important that the technology doesn't become a barrier, because in the end, healthcare delivery is about delivering to the patient. So the technology should be a support element to that. It shouldn't be a distraction in delivering healthcare professional. And it shouldn't be a distraction for the healthcare professionals. Then obviously you have to have some platform-specific training, but if the user interface is intuitive enough, the amount of platform-specific training required should be very low. And then obviously when you're looking at migrating from paper-based registries, this has to be done iteratively, and there's the ongoing issue of stable infrastructure and electrification. So in some countries, like Kenya, for example, all of the healthcare centres that we worked with, they were all connected to the grid. But every time there was serious rain or during the rainy season, then those healthcare facilities had issues with electrification. So our solution to that in part was to propose the use of laptops, which in these specific countries was considered to be quite unusual, because normally in a healthcare center you have a PC, a power, a tower, you lock it in a room and you ensure nobody can interact with it. So the idea of giving laptops and tablets to healthcare professionals was quite a new idea. So then in terms of achievements, over the length of the intervention, we developed a state-of-the-art patient-centric healthcare system, and it was designed to improve both primary healthcare delivery and, in our case, also healthcare delivery in the context of referral hospitals in Kenya. We had to be able to work in an offline and online mode. In our case, it was co-designed and validated with ministries of health, district health offices, and clinicians across 4 countries that have different environments. And we validated in a mix of hospitals and primary health care facilities, which had a catchment population of over 875,000. And we used a wide range of medical programs, which were configured based on analysis of paper-based systems and inputs for the clinicians, but ensuring that the medical programs were relevant for all 4 countries. And then it was available in English and French, and potentially other languages could be added. So then in terms of next steps, we wish to continue validating the system functionality in the programs with healthcare facilities and countries that weren't involved in the initial co-design process, and we're looking for support to scale implementation in the existing beneficiary countries and new countries. And then here I give you links to some online resources, so you can see the video that we didn't manage to show very successfully now of the functionality. And then we also have a number of videos from the healthcare facilities where the beneficiary end users talked about their experience. Thank you very much.